So I'm going to dovetail from George's nice talk earlier on anatomic shoulder arthroplasty, current concepts in the future. So here's an overview of what I'd like to talk about today, beginning with some history and historical perspective, current design trends, implant selection, speaking a little bit about humeral stem length, glenoid considerations, and some of the surgical planning tools which we have available to us today. George nicely highlighted some of the software which is available for us today. More information is always helpful as we plan our surgeries and improve outcomes and minimize complications. We have now, beyond just planning tools, surgical precision tools, which include intraoperative guides, which we saw earlier. And moving forward into the future, more and more, I think we're going to be leveraging mixed reality, augmented reality, and other tools to enhance our precision as we move forward. And here's a picture of me a couple of years ago experimenting with some new technology and some goggles which allow us to see on the actual patient's anatomy what we planned prior to surgery and future directions. And we can see into the future and the robots are coming. So it's hard to believe that we've come such a long way from the first shoulder prosthesis, which was reverse, obviously, rubber and platinum, and coming from the great French gynecologist and obstetrician, Jules-Émile Payan. And the modern age of arthroplasty began with Charles Neer, and at the time, nearly 70 years ago now, we only had one option to fit to all patients, which looking back was not ideal. We had fixed inclination version and offset, and no cement and no glenoid componentry until nearly 20 years later when we introduced cement and glenoids. And then into the late 1980s, we introduced modularity with the Kirschner and the Global and the Select prostheses, but again, fixed geometry, and with these came positioning errors and occasionally poor outcomes. With the work of Christian Gerber and others, we began introducing three-dimensional modularity, where we were able to more accurately reproduce version, offset, inclination, and as we know, anatomy varies from patient to patient, and this has an impact on our results. Moving on a little bit later, we saw the introduction of platform systems and the ability to go from anatomic to reverse without revising the humeral component. But what we saw in the early stages was that perhaps in theory this worked better than it did in clinical practice, and we would overstuff the joint and have difficulties with this. And so we began to think about what may be more applicable, which would be revisability or easy removal versus convertibility in some cases. And so with this, we began introducing shorter humeral stems. The Biomet Mini and the Tournier Ascend were some of the early devices on the market. But what we found with some of these earlier designs was stress shielding at the calcar, and so this led to redesigning and adding a proximal porous coat, which helped to mitigate this to a degree. And here are some other devices. This one allowed for in situ reproduction of inclination and offset, but these were easier to extract. And so moving forward, at least in the United States, we benefited from the European experience of stemless arthroplasty and worldwide, and for us at least this was introduced in 2013, bone preserving, less stress shielding at the medial calcar, easier revisions, and ideal for deformity cases as we see here, where we were able to disconnect constraints from the proximal deformity into the humeral canal, mitigation of periprosthetic fractures, which was achieved with stemless. And what we found more and more as we looked at the literature and our experience was that humeral component loosening as a whole was very rare. The advantages of stemless arthroplasty have been well proven in the literature: a reduction in blood loss, operative time, less post-op pain. And in my practice, at least today, for an anatomic arthroplasty indication, stemless is comprising at least 90% of my anatomic arthroplasties. And more, we're moving to outpatient arthroplasty, and so for these variables, it's very important: less post-op pain, less blood loss. These patients are being discharged more and more on the day of surgery. This is a nice meta-analysis, the largest published review of stemless from Peter Habermeyer and colleagues, nearly 1,000 cases, mean follow-up of over 2 years, and no clinically significant component loosening with stemless. This is the largest U.S. published series, which I was a part of. We looked at the eclipse, comparing this to the universe, and across 16 sites in a 2-year follow-up, we found clinically significant improvements in pain and function, and no implant failures across the board. So where are we going moving forward? I think we're in the age of precision medicine, and what is precision medicine? It's a medical model that proposes the customization of healthcare with medical decisions, treatments, practices, or products being tailored to the individual patient. It's data-driven, and patient-specific intraoperative guidance and implants are a mainstay of this. What will this software and technology not assist with potentially? Clinical indications and patient selection. And we saw earlier arthroscopic debridement, for example, or in younger patients or more active patients being a more feasible treatment. You're not going to consider arthroplasty in a patient who has high activity demands such as this. Software and PSI will not assist with surgical technique, and so as we all know, exposure of the glenoid, good exposure of the glenoid is critical to implant anything successfully and accurately, let alone guides. And then obviously surgeon experience is important, and there are cases that I've seen where even the planning software can mistake what you see intraoperatively, and so guidance and experience can dovetail together. So what are the indications for TSA, anatomic TSA, pain and loss of function that is unresponsive to conservative treatment in cases of advanced osteoarthritis, inflammatory arthropathy, etc. An intact rotator cuff, as we heard earlier, is critical for an anatomic arthroplasty to perform well, and also satisfactory glenoid morphology. So in some cases of more advanced retroversion or bone loss, reverse arthroplasty may be indicated. We begin with preoperative planning and x-rays. We're looking for static instability. We're looking for proximal migration. We're looking at the axillary lateral as well for static instability and suggestions of perhaps subscapularis insufficiency, but the axillary lateral plane radiograph is not accurate in really understanding glenoid morphology. And so for me at least, I like to perform a CT scan in all cases. It allows for precise calculation of version, morphology, and then you do get some information regarding the rotator cuff, perhaps not as accurate as MRI, but certainly helpful. And finally, the CT scan is required for all these software planning tools that we have available to us today. And so there are a myriad now. Every company, every implant company seems to have their own preoperative planning software, and so I think the critical element is to understand one and to go through the process internally before you get to the operating room to perform a better executed plan. We have some nice published work from Dr. Golke and colleagues demonstrating that three-dimensional planning was more accurate than two-dimensional CT scans. And what is really the goal of this is for preservation of glenoid bone stock. And so this is another study by Joe Ionati, really a pioneer in this space early on, and showed that compared to 2D imaging, three-dimensional imaging improves significantly placement of the glenoid component using patient-specific instrumentation. So this is a patient of mine from 2004, 58-year-old male, advanced OA. And so in the old days, this is a study that we did with Christian Gerber. We would use the CT scan and this intraoperative protractor, if you will, to cannulated ream and perform a degree of correction during surgery based on our preoperative plan. And so we did controlled eccentric reaming, and at 12-year follow-up using this prosthesis, the patient continued to do well. But what would I do today? Today we have more tools at our disposal. We have better planning software, intraoperative guides, and so for this type of case, I would utilize these technologies to preserve glenoid bone, avoid aggressive corrected reaming, and potentially use an augment, as George showed earlier. On the humeral side, I've moved more towards short stem or stemless devices. And again, glenoid bone preservation is critical. And so this is a nice study by Gilles Walsh. At 5 and 10 years, he demonstrated that radiographic survivorship falls off 50% nearly at 10 years. But thankfully, radiographic loosening did not always correlate with clinical failures. And so sites with aggressive reaming led to early failures more remarkably. So this is a case similar to what George showed earlier, type C glenoid in a 51-year-old male, 30 degrees of glenoid retroversion. And so we go through the process of planning. Here we're going to consider eccentric reaming. But the challenge with this is over-aggressive medialization of the joint line and loss of bone. So this was abandoned to achieve this. And so we plan instead for an augmented glenoid construct, which achieves satisfactory seating and a good outcome. So given that George showed something similar earlier, we're going to skip through this, but we have a 3D printed model, intraoperative guides, and so we can execute the plan to achieve something like this. This is a nice study by Dr. Favard looking at patient-specific guides and their early experience in 10 patients, and the key conclusion of this was that the planning software was helpful, but one of the challenges is poor performance of using these guides in controlling rotation and reaming. So more work is to come with technology. What are our opportunities for improvement? I think that it's one thing to conceptually insert the guides, but we need to do better in terms of recreating rotational control, depth of reaming. Adequate glenoid exposure is a challenge for some less experienced surgeons, and calculations of much of this preoperative planning software can be impacted by osteophytes, so it can erroneously overestimate deformity. And so what does this open the door for in the future? Robotic assistance, which is currently in development and will be here soon. And so the future, I think moving forward, is really incorporating the planning software, mixed reality goggles and tools, and then ultimately robots. And so here we have the Mako from Stryker and the Rosal from Zimmer Biomet, and the robots are certainly coming. So in conclusion, anatomic shoulder arthroplasty provides durable pain relief and functional improvement in patients with advanced glenohumeral osteoarthritis. Preoperative planning software and PSI guides enhance our ability to translate our virtual plan into reality with enhanced precision, especially in complex cases. Mixed reality and robotic assistance are on the horizon and in development. But I think ultimately, as with all new technologies, further work and research will be required to demonstrate whether or not these technologies actually improve outcomes and to what degree they drive value. And so this will drive further implementation moving forward. Thank you very much.